Welcome to Clinical Challenges in the Management of Complex Patients with Type 2 Diabetes Mellitus, presented by Albert Einstein College of Medicine of Yeshiva University at Diabetes Series Live. My name is Tracy Mitchell, and I will be moderating today's sessions. Today is the first segment in this two-part educational series, and our first session is titled Overcoming Disparities in Diabetes Management, Real-World Strategies That Work, with Dr. Monica Peak. Before we get started, I would like to remind you that today's session is a live interactive program that allows us to take questions in real time throughout this presentation. I encourage you to send us your questions anytime by typing them in the box located at the lower left-hand side of your screen. I'd now like to introduce you to our presenter, Dr. Monica Peak, Assistant Professor in the Division of General Internal Medicine at the University of Chicago. In addition, Dr. Peak is Associate Director of the Chicago Center for Diabetes Translation Research. Welcome, Dr. Peak. I'll now turn the program over to you.
Wonderful. Thank you so much for having me. I'm delighted to be here today, and we're talking about overcoming disparities in diabetes management, real-world strategies that work. So things that we can think about as clinicians to try and help our patients, which often have more complications and more difficulty managing their diabetes. I'm going to start by talking more broadly about disparities nationally and some of the national trends that we see and things that may be on our minds as far as reducing diabetes disparities, and then talk more specifically about the work that we're doing here in Chicago to try and reduce disparities in diabetes and use that as a case study. I'm going to try and keep my overview brief so we have enough time at the end for questions, for more detailed information about the program, or just other questions in general. So I'm going to first start out by just showing a brief trend of the diabetes prevalence, so the number of people who've been diagnosed with diabetes in our country, and that continues to escalate. And we're actually seeing an epidemic of diabetes that is largely driven by our obesity epidemic. This map here shows the United States in 2004. Areas that are darker have prevalence rates of greater than 11%. And you'll see that compared from 2004 to 2005, 6, 7, 2008, and then 2009, which is the most recent map that was released by the CDC, we have darker and darker areas. So there are more and more states that are having higher prevalence rates of diabetes. So we see that this trend is continuing, and when we look and forecast what we plan to see in the next 20 years, the rates of diabetes will continue to escalate unless we are able to turn this tide. And so some of what we think about are the public health strategies as well as the individual level strategies to help people who've been diagnosed manage their disease. In addition to diabetes just being a huge national problem, we know that there are some populations that are more vulnerable to not only being diagnosed with diabetes, but having complications and suffering a range of problems because of their diabetes, and we call those diabetes disparities. Here within Chicago, just like the rest of the country, we see disparities in diabetes that are based on race and class. So this is a map of the city of Chicago, and it just shows the various communities that are within our city. The communities in green are ones that are predominantly African American. The community areas that are in yellow are ones that are primarily Latino. And this is a map of diabetes death rates. And so you'll see that the maps that showed areas that were primarily racial and ethnic minorities have higher rates of diabetes-related death. And this is from 2004 to 2008. Since then, the trends have continued. And then this is a map that shows years of potential life lost. So higher levels, higher numbers of years of life that's lost because of diabetes in our racial and ethnic minority communities. So it's a huge challenge that we think about and that we're facing as a country, but also as clinicians when we see these patients actually within our practices, within our emergency rooms and hospitals. When we talk about health disparities, it's important to know that there are two kinds of health disparities, and they're related. So there are disparities in health care, so the kinds of care and the kinds of treatment that we actually give patients when they come to the hospital setting or we see them in clinic, and then disparities in health status. And certainly what we do in the office matters. If we're able to provide high quality care, then ideally people would have better quality health. That's why we're all here. But there are things that are outside of the healthcare system that still impact people's health. And so it's not just enough to think about healthcare changes when we're trying to impact people's health. So when we are thinking about healthcare and things that we would do, those are what we call health systems change. But in addition to system change within the healthcare system, we need to be thinking about changes within systems that are outside of healthcare if we ultimately want to impact people's health. So thinking about what we can do as clinicians in healthcare, but also as clinicians working outside the healthcare system and working in partnership and collaboration with other institutions. And I'll talk a lot about that today. For those of us who are watching, who are researchers, you may have heard the term process measures or outcome measures. And we always want to know if what we're doing is effective. Are we actually having an impact? And process measures are really those things that try and assess what's happening within the healthcare system. So when we're trying to make changes, trying to increase our rate of influenza vaccinations, those are process measures that we're tracking and that we're trying to see if we're making improvements on. And ideally, what we do in the healthcare system has an impact on people's health. So it impacts outcome measures. And those are things like the actual rate of diabetes control, the vaccination rate for people who've had influenza, the number of people who have their blood pressure controlled, the rates of cardiovascular death. And so actual health measures that we want to see change as a result of process measures. But again, those health measures are in part driven by the communities in which people live, as well as the healthcare systems that they're able to address. And so it's important for us when we think about tackling real world disparities that we keep these two systems or these two frames of reference in mind if we're really hoping to help our patients and to see some reductions in disparities and improvements in health outcomes. So we'll talk a little bit just about health system contributors to diabetes disparities. And it can be sort of broadly thought about as differential access to care and then differential treatment once you're within the health system. And so for differential access, we think about the uninsured versus the insured. So people who have no insurance at all and have a more difficult time getting into the healthcare system except for emergent and urgent care versus those who have insurance. But it's also really important to understand that even for those who do have insurance, there are tiers or there are differences in quality of insurance. And so, for example, there are many providers who don't accept patients who have Medicaid. So they may be insured, but their provider may not accept their rates of insurance. And this has particular implications as we are seeing the development of the health insurance exchanges. And so we have new types of health plans that are coming on the market. And a lot of these are sort of the basic coverage that would care for people, but not the Cadillac plans of health care. And so various providers may or may not accept some of the kinds of health insurance plans that are on the market. So it's not just enough to have insurance. You also have to think about the kinds of insurance that people have when they're trying to figure out what kinds of health care, what kinds of services they can access within the health system. Within the health system itself, once people are actually to make their way into the doors, then there's still differential treatment that we see of various vulnerable groups. So when we look particularly at racial and ethnic minorities, but it's the same for the elderly, for people who are coming from other challenging backgrounds, we see that there are differences in the kind of care that we deliver despite the fact that we're in the same health system. And so this is an area where we really can use quality improvement techniques to try and address some of that. So efforts to try and improve the quality that's delivered for all patients, but particularly keeping with a health disparities lens in place so that we're making sure that we're actually reaching all of the patients that are within the health system for these kinds of improvements in the healthcare system that we're trying to make. And so those are some of the structural things when we think about quality improvement, but health systems and health operations are made up of people. They're physicians, nurses, front desk staff, lab technicians, and all of those people together with the health system make up what we consider to be our healthcare organization. And so we also know there's actually a fairly strong and robust body of literature that shows that physicians and healthcare workers are just like everyone else. We carry our own biases, and that those biases can impact the kinds of care and decisions that we make about treatment for patients. And so it's important for physicians and patients to be able to recognize